For our next session, I would like to call upon Dr. Ramesh Mundle, sir, who is a senior physician from Nagpur and is also the scientific co-chairperson of the CME. Sir will be delivering his lecture on iron deficiency anemia. To chair this session, I'll call upon Dr. Ketan Modak, sir, Dr. Anand Kate, sir, Dr. Ram Godhani, Dr. Jayant Vaghela, and Dr. Kapil Barvin, sir, on the stage.
Well, right at the outset, I have to thank Dr. Shrikant Mukhewar for giving me this opportunity to speak on a very simple topic, iron deficiency anemia. Chairpersons, I would start. It's a leading problem all over the world, and it causes a lot of morbidity amongst women and children. The major cause is reduced availability of the iron in the diet. It may be either absorption problem or it may be acute or chronic blood loss, which results into iron deficiency and anemia. India, as we all know, is leading in so many other ways. Iron deficiency is also a major cause of anemia in India. The global burden is also very high, and there is a very high proportion of people who have iron deficiency anemia in the world, especially women in the age of 15 to 49 and children below 5 years. Older adults also have incidence for some different reasons. Around 12% of older adults more than 65 years of age may have anemia at a given time. And India, of course, has the largest burden of anemia. What is the national prevalence? So we have iron deficiency and iron deficiency anemia both. Iron deficiency is more common than the anemia itself. It affects a large population of India, especially females in the childbearing age and children. The National Family Health Survey says that around 57% of women in the age group of 15 to 49 and 67% of children are under 5. They are anemic at any given time. And it is said that it affects 1 in every 5 women worldwide. The rural areas and the low socioeconomic group also have significant contribution to iron deficiency. Now, what's the normal iron content? The total iron stores around 3 to 4 grams, out of which around 50% is in the RBCs. The iron containing proteins like myoglobin, they consume around 400 milligrams. The plasma iron is 3 to 7 milligrams. And you have a huge store of iron in the liver. It may be around 0.8 to 1 gram in males and 0.4 to 0.5 grams in females. Now we come to how iron absorption is regulated, its uptake and distribution. The dietary source of iron is in 2 forms. The non-heme iron, which majority of us consume, and the heme iron is just 10% of what we get from our diet. The non-heme iron is difficult to absorb, but the heme iron is more easy to absorb. But it all depends upon the hepcidin. If you have the liver cells full of high hepcidin, or the cells in the intestine, the absorption of iron is less as compared to the organs where the low hepcidin intake is there, or the state is there. You will find more and more iron is absorbed. And finally, the iron binds with the protein and taken to various tissues. Now, this is a chart which shows the factors which influence the size of red cells anemia. In the center, you will find the normal hematopoiesis. On the left side, you will find defective hemoglobinization, either because of iron deficiency, thalassemia, or sideroblastic anemia. And finally, it ends up with a small RBC as compared to the normal. On the other side, you have a normal iron, but you have defective DNA synthesis because of B12 deficiency or folate deficiency. You are taking cytotoxic drugs, or you have something called as myelodysplasia. So the hemoglobinization is normal, but the cell size is more, and that is why you find a high MCV or macrocytes. Now we can think of having 3 different stages of iron deficiency anemia. The first stage is just iron depletion, nothing. The stores are depleted, but hemoglobin is normal. The synthesis of hemoglobin is normal. But symptoms are because of iron deficiency, and these are almost the same as what we get in anemia: fatigue, big excess tolerance, pica, restless leg syndrome. You find that hemoglobin is normal, but the ferritin is low, the serum iron may be low, the transferrin may increase. The stage 2, we show that we find that the patient has some mild anemia. It may be sometime normocytic, normochromic, but the lab findings will definitely show low ferritin, low iron, and high transferrin. The third stage is the obvious stage which most of us see in clinical practice, that is severe deficiency of iron, resulting into microcytosis, hypochromia, and the RBCs look smaller than normal, with a typical finding of low MCV, low MCH, a low reti count, and there may be sometimes the picture may be slightly dimorphic because they may have associated folate deficiency or B12 deficiency. Now, what are the common causes which we all know? This is just a revision of poor dietary intake. There may be insufficient consumption of iron-rich foods such as meat, poultry, seafood, iron-fortified cereals, and green leafy vegetables. It can lead to inadequate absorption and resulting in anemia. Some people develop chronic blood loss because of menorrhagia or a GI bleed or some internal bleed, and can just go on depleting the source of iron and finally become iron deficient. Sometimes malabsorption plays a role in iron deficiency anemia because there is something called a celiac disease or tropical sprue, which predominantly affects the small intestine, the jejunum. Iron is absorbed predominantly in jejunum. Sometimes Crohn's disease, gastric bypass surgeries, they can limit the body's ability to absorb iron, and this is how it leads to deficiency. And of course, this is a physiological point, increased requirement. Certain stages of life like pregnancy, childhood, adolescence, the body's iron requirement increase. And that is why if the iron requirement is not fulfilled, it can result into iron deficiency. Now, what symptoms can arise because of iron deficiency? So remember, iron deficiency anemia has symptoms more because of iron deficiency than anemia. Like common symptoms are fatigue, exercise intolerance is poor, they have typical pica, means craving for non-food items like ice or mud or chalk. Some of them may have restless leg syndrome. Some people may also complain of hair loss, headache, and bituria. As the anemia becomes more severe, they develop fatigue, irritability, palpitations, shortness of breath, and sometimes in severe cases, one may find they are decompensated and come with congestive heart failure. The typical physical findings are pallor, dry or rough skin, atrophic glossitis, that is the smooth tongue, angular chelosis, some of them develop platynachia or koilonychia, and severe cases may show signs of hemodynamic instability, tachycardia, gallop rhythm, raised JVP, etc. Pica is something which is very common in iron deficiency anemia, and I think that craving can be of anything, but it's more of ice for ice and the soil or the chalk, something like that. Bituria is seen in, those who consume beet. Iron deficiency anemia patients, they may develop that pink colored urine. And it is said that almost 40% of people with iron deficiency may have restless leg syndrome. This is a typical pictorial view of what can happen in the fatigue, pica, pallor, weakness, decreased concentration, koilonychia, conjunctival pallor. Sometimes there can be presyncope, dyspnea, tachycardia, angina. Some people may have some psychiatric symptoms like anxiety, depression, irritability, and headaches. Now, when we evaluate patient of anemia, suspected iron deficiency, you have some at-risk populations. And these are people who present with unexplained anemia, especially the microcytic hypochromic anemia without reticulocyte count increasing. Some symptoms which may only come to patient may come only with symptoms like pica. All pregnant women must be investigated for iron deficiency. And in fact, even for chronic kidney disease, iron deficiency can be responsible for anemia. So you need to evaluate these patients. So you get a complete blood count. You find the reticulocyte count should be low, and one always has to look for peripheral smear, which is the hallmark of diagnosing iron deficiency anemia. So you find that the patient has a low hemoglobin, the hematocrit is low, the MCV is low, the MCH is low, the REW is high, and there is typical microcytic hypochromic anemia. Now, how do you confirm anemia? By and large, most of us, they rely mainly on peripheral smear, but yes, if you really want to know whether it's iron deficiency or not, because sometimes you may find some differential diagnosis for such peripheral smears. So get a serum iron, iron binding capacity, transferrin saturation. Ferritin levels are more useful, and sometimes you can even think of a special machine like soluble transferrin receptor. Bone marrow is rarely required, but when I was a house officer, many anemic patients were investigated with bone marrow, and that staining for iron in bone marrow was the hallmark for diagnosing iron deficiency. Remember, serum iron is low in both iron deficiency as well as anemia of chronic disease. Transferrin increases in iron deficiency, but it decreases in anemia of chronic disease. And ferritin, if low, indicates iron deficiency. But remember, ferritin can be affected by so many other factors, especially inflammatory states. So sometimes ferritin may be slightly higher and then you get confused. This is the typical peripheral smear of a patient who has got microcytic hypochromic anemia secondary to iron deficiency. Now there is a panel of tests which we perform in patients of the same test, like serum iron, iron binding capacity. So iron deficiency without anemia, serum iron can be normal. Iron deficiency with mild anemia, serum iron is around 60, less than 60, and with definite deficiency with severe anemia, it is less than 40. The iron binding capacity will gradually increase as the anemia increases. Saturation also would drop down as the anemia increases. The hemoglobin may be normal in pure iron deficiency without anemia, but it falls to less than 6 sometimes in patients who have got severe anemia. But serum ferritin, usually you'll find in pure iron deficiency, serum ferritin is always low. With mild anemia, it is less than 10. And in severe deficiency, it may be less than 10. I mean, maybe 5 we have seen as serum ferritin. Now, what are the treatment options? The most important is the dietary iron supplementation. You have to make an effort to increase the diet which is rich in iron-rich foods. You have another option, which is normally we prescribe oral or sometimes parenteral iron. And one must try to find out some underlying cause for anemia. If it is obvious on history, it's okay. Otherwise, we have to investigate the patient accordingly. Now, what is the dietary supplementation? Find out iron-rich foods. Most important is red meat, poultry, and fish. The non-heme iron is present in lentils, beans, spinach, fortified cereals, jaggery, and dates. Vitamin C always would increase the absorption of iron. But if you take calcium or sometimes tea after meals or some phytates, they definitely would inhibit absorption of iron. These are all iron-rich foods like spinach, lentils, heme iron, fruits, peanut, chickpea, and almond. Now the factors which affect absorption, how many minutes? 2 minutes, fine, I'll finish. The heme iron is absorbed 25% of consumed. Non-heme iron is just absorbed 10%. If you add vitamin C, absorption increases to 65%. If calcium is present, absorption drops to 20%. If inflammatory diseases are present in the patient, the absorption would drop to 12%. These are some preparations for oral iron. Like usually we use ferrous sulfate, gluconate, fumarate, ascorbate. The dose is around 100 to 200 milligrams per day. And preferably to be taken on empty stomach for best absorption. You have to manage the side effects and have to counsel the patient for these things. Now, parenteral iron therapy is becoming more popular, especially those who have severe anemia. Because if you have a patient who has severely anemic and who has oral intolerance, severe anemia requires rapid correction, including patients who have chronic kidney disease who are iron deficient. The preparations, as you all know, iron sucrose, ferric carboxy polymaltose, and iron dextran. How do we monitor the patient? Do reti count after 7 days or hemoglobin after 10 days. The average rise should be 1 to 2 grams per week or every 10 days. And the ferritin transferrin saturation, if you do, you should do only after 8 weeks. The duration of therapy is after treating the anemia, the patient hemoglobin has risen to your desirable level. Continue iron for 3 to 6 months to replenish the iron stores. Blood transfusion is rarely indicated except in patients who have got severe anemia, who have hemodynamic instability, or patients who come with cardiovascular compromise. Repeated transfusions are avoided for iron overload, transfusion reactions, and infections which can occur because of blood transfusion. So, if you have to prevent the recurrence of anemia, address the underlying cause like GI bleed or menorrhagia, and consider long-term management with low-dose iron for high-risk groups. So, the nutritional education for these patients is eat red meat if possible, not possible for all people. Consume poultry, include seafood. This is quite possible on the seashores, on the eastern and the western side. Eat more legumes, eat fortified cereals, and try to be more compliant with the food intake. The last message I would like to give is कि even if somebody comes to you with अच्छा नहीं लगता, थका थका लगता है, palpitations हो रहे हैं, irritability है, बच्चा स्कूल में पढ़ता है लेकिन ख्याल में नहीं आता है, suspect that he may not be anemic, he has iron deficiency. So add iron in his diet and you would find different results, better results. Thank you very much.
Thank you, sir, for a very brisk and crisp presentation about iron deficiency anemia. And you have covered almost all the points which were to be covered. If there are any questions from the audience.
I think it was a revision for everybody to have deficiency anemia. Yeah.
Thakan, lack of concentration, where you suspect iron deficiency rather than anemia. The hemoglobin may be 12 or 12.5, but these patients show very low ferritin value. So I think ferritin is must in all multi-specialty practices also, and you should that will give answer to many other questions.
Right.
Rather than only following hemoglobin.
Sir, stool occult blood on iron.
Yeah.
What is your take home? Because normally we ask our patient to stop the oral iron so that they should not give false positive. But then in between, one of the hematologists said that it is not necessary to stop the oral iron therapy for testing of stool occult blood. I don't know what
I
it
am also not sure. Maybe.
No, we don't need to stop.
We know because
Why?
because it tests heme oxygenase, not the iron.
Oh.
So that will not. But sometimes calorimetric, the stool color may change, so it
Yeah.
may cause wrong readings, but it doesn't interfere with. So it's not required to be stopped.
Sir, what is your preferred injectable iron?
Difficult. I mean, most of the times we use carboxypolymaltose combination.
Is there any role for histogram? Many pathologists give all those histograms. Maybe you may answer, any pathologist may answer here about the role of histograms to diagnose the iron deficiency, the mixed types or the megaloblastic type based on the histogram studies which would come up in the reports.
But I think even Ketan would agree with me, with not only histogram, you need a peripheral smear to confirm the finding the histogram. Ketan, would you like to answer?
So many a times I agree, sir. Histogram helps, but nowadays we get lot of values like MCV, MCH, RDW, which usually we don't need to look at the histogram many a times. Peripheral smear should be the first investigation we should be doing, and based on that we should be asking for further investigations. Just to add one point to what sir has already discussed regarding the management of iron deficiency. So there have been lot of advances in understanding the pathophysiology of iron deficiency anemia. We know the role of hepcidin, ferroportin and all. So we don't need to give thrice a day iron anymore. Once a day iron or even alternate day iron is sufficient. Oral iron I'm saying. Regarding sir's question of IV iron, FCM is good agent, but there have been risk of hypophosphatemia over the period of time. Iron isomaltoside doesn't cause it, but there have been some fish-bane reaction associated with iron isomaltoside, which are relatively easy to manage once we train the staff.
Yes.
Sir, the older preparations, yes, but there have been newer preparations like liposomal ion preparations
Right.
or polypeptide ion, which can be consumed with meal.
Okay. And it has to be given always with vitamin C.
So even the newer preparations, they are saying you don't need vitamin C also.
Okay.
Sir, one question from my side. In a resource constrained setting, a patient having symptoms with moderate anemia, what is your advice regarding treatment oral versus parenteral? Rather, we should be
If a
aggressive.
patient is tolerating oral iron, I think oral iron is very effective. I give you an example of a lady who had come to me, very poor lady. Her hemoglobin was 6 grams and she said, nothing doing, माझ्याजवळ कोणी नाही आहे, मला मुलगा नाही, मुलगी नाही, मला 6 महिने औषध लिहून द्या, मला 6 बाटल्या घेऊन जाते. So there was one preparation of glycocorticoid fursolate. So I prescribed her. After 6 months she came to me, her hemoglobin has gone from 6 to 50.
Thank you, sir.
So
Well,
it is equally effective.
2-3 things. Whenever we give iron pills to any patient, what is most important is to know what is the elemental iron in that. Nowadays, most of the pharma companies would always tell you that this would not cause any constipation, this and that. The reason being that there is only 30 milligrams of elemental iron, and that is really a very poor iron content if your hemoglobin is 6 grams. Now, two small questions. Is there any role for Mertes index, MER, TIZ, and if pathologists may answer? And number two, in our clinic at least, all patients who receive IV iron, we prime them with 50 milligrams of hydrocortisone, because many a times patients go home and get high-grade fever, body ache, this and that. And whenever we have done that, the incidence of side effects has become very low. What is your take on this?
No, I'm not sure. We never use hydrocortisone, and 30 milligram of iron is sufficient, non-heme iron, to make around 2 to 3 milligram. But that is the usual requirement. 1 milligram for an adult male and 2 milligram for an adult female. So I think 30 milligram should be sufficient. Available iron as 30 milligram should be sufficient to make an absorption of around 2 to 3 milligrams.
So newer preparations, what they have studied is a liposomal ion, the absorption is excellent. So the liposomal ion comes in as a 30 milligram, which you are talking about. And with that, we have never found any problem when we are using for our patients. Only thing is it is little costly. So it's not easy to use for all the patients. It's slow. I agree. So, but we we give it on a once a day basis or sometimes alternate day basis. And tolerance wise, it's very well tolerated. Even in pregnant females, we have used that where already they have a lot of issues going on, and it's.
There are certain conditions in which only injectable iron is advocated. For example, patients who have congestive cardiac failure. And there is a role of, they specifically recommend that IV iron should be given instead of oral iron. Similarly, in patients with CKD, with anemia, and may have a co-associated. What's the whole idea behind it? They just don't recommend oral iron. There is a specific role of injectable iron. Any idea about that?
In GI conditions, we know the absorption is the issue. Even in CKD, what studies have shown is oral iron doesn't have that much of elevation in hemoglobin as compared to IV iron, mostly because it's a functional iron deficiency rather than the overt iron deficiency. So no specific IV iron combination which needs to be preferred. Any combination can be used. But definitely in all these chronic conditions where ferritin is slightly higher but T-sat is low and we label them as iron deficiency, IV iron would be more preferred. Thank you so much, sir.
Thank you so much. Thank you, sir, for the very informative session. Thank you to the chairpersons for your valuable inputs.